Well, good morning, afternoon, evening, wherever you are. Today, I'm really excited. I'm really happy to be with two great colleagues from literally one side of the world, one and the other in just the opposite. But we have a common interest, which is sepsis. Thank you, Suchitra Ranjit from Chennai, India. You're a fabulous researcher, a real leader in the world of sepsis, and Roberto, who is in a national day in Argentina because you won the World Cup. So welcome the both of you. And my first question to you to start this conversation is, Suchitra, what is sepsis for you?
Yeah, I think that's the most difficult question. Yeah. So I guess the standard definition is a dysregulated host response in the presence of an infective pathogen. That's a safe response. Although it's a bit of a textbook response, because how would you really guess that the child in front of you had a disorder? The standard definitions when there's an infective pathogen and a dysregulated host response in the patient. But this definition is not helpful for the clinician at the bedside, because how is the clinician supposed to measure the host response, whether it is regulated or dysregulated?
At the bedside.
So we need, yeah.
So
what do you think, Roberto?
If I am taking care of a child, when do you think, well, this child has a dysregulated immune response, so this child should be taken care in a different manner from those other child you take care every day with fever, they are sick, parents take him or her to the physician. But how can I detect that? What is and I think I know that this is a difficult response, but when do you say, well, this child is different?
Yeah, so that's for me, the question, or Roberto?
For both of you, because I think we can have a common response, but I want to hear you both.
Yeah, Roberto, would you go first?
For me, there is something interesting in this. I have a daughter that she's studying all about the word and how we spell the words in language and the meaning of words. It's very interesting to know that sometimes we got this difference between definition, the one that Suchitra has said just seconds ago, and the other is the different what they mean. What is the meaning of that word, and how we can make that concept that maybe sometimes they are abstract, because if you say sepsis, is some word that is there, but maybe it's difficult to recognize what is sepsis. How you put this sepsis in real world, in real points, so the physician bedside, the patient can recognize sepsis. And I like the point and the position that some kind of our colleagues, adult colleagues, said about the clinical criteria. And I mean that this These are two different things that maybe in some part of the world, they are different, because sometimes definition for the English speaking world or the French speaking world is something, but sometimes definition for us is like the concept, and the clinical criteria are the points how we recognize, how we put sepsis word in the patient. So I always try to say to the students, to the young physician, to the other physician, that first of all, if you have a patient with fever, with infection, take a look how it looks. If it look good, if it look bad, if it look tachycardic, if it look tachypneic, how is the skin, the diuresis, and it have diuresis. So you must think in sepsis. It doesn't mean that you have to treat like a septic shock, but try to think in sepsis, and that will make you be some kind of alert what it have, what to do again. And I love that concept from Suchitra that she says, take a look what the patient says to you. Take a look to the patient. What is saying to you. Listen to the patient. Listen to the physical, the clinical criteria he's saying to you. And I love that phrase from Suchitra. And that's for me. Sepsis, as Suchitra said, is some kind of dysregulated response, immune response. But the clinical criteria maybe is different for a guy with tuberculosis, with dengue, with malaria, with staphylococcus, for example, or with bronchiolitis.
But you are, and a very interesting thing about this, about what sepsis is that whenever I call to physicians working at the emergency department and the ICU or at the floor, the general ward experts, they all say to me, listen to your gut feeling and listen to those parents when they say, hey, this is not my kid. So, but we are intensivists, and we adore to put into numbers this subjective criteria, this gut feeling. So how can we put into numbers, into some objective measure, what sepsis is? And there we have this SEERS criteria plus feverish child with an infection in course, but not many people agree that SEERS is useful, in particular for adult populations. But we are pediatricians, so Suchitra, how can we do, or what can we do to put into numbers, if needed, this gut feeling, this thing that, well, this child is sicker than the rest of feverish children?
Yeah.
I don't know
so
if I'm clear, because what is sepsis is the most difficult question.
It's the most challenging question.
Yeah.
So I suppose, like what Roberto was talking about, is the excess tachycardia as going into kind of shock and a circulatory organ failure. And in the early stages, they have sepsis. And one useful construct is the concept of remote organ dysfunction, but you may need a lab for it. For example, a child with a pneumonia has every reason to be tachypneic, maybe a bit tachycardic, and needing oxygen and working
Yeah.
hard.
Yeah.
But if his urine output is dipping, that means it's a remote organ failure. If his platelets are down, it's a remote organ failure, or his liver enzymes are elevated. So all of those tells you it's kind of not just, it's a blood, it's going to the entire body and the organs are, so that way, that's how I teach my students. So
Okay.
whenever there's an unexpected organ failure, which is out of proportion to the focus, to the initial infecting syndrome,
Mhm.
then it's probably a little more serious. And it's actually a good justification to give a little broader antibiotics. Whereas if it's just confined to just the lung for a pneumonia, you don't really need to cover so broadly, and you need to monitor, but it'll be just that organ.
Mhm. So a pneumonia, not all pneumonias are sepsis. I mean, you can have lung failure, for example, but if you detect both from the clinician perspective in the clinical exam or by some lab exam, might be inflammation far away from the lungs, then you have to start that inflammation is dysregulated. I'm
Correct.
thinking clear on your point. Roberto, you were trying to say something.
Yeah, that's a good point. Several months ago, we have Suchitra WhatsApp group, almost 260, 270 pediatric intensivists all around Latin America, North America, Spain, Italy, Portugal, that we always are talking about some of these points. We call it like we are in some kind of working together at the same time, all the 250 or 60 intensives.
Right.
And there was a talk about what is sepsis. And at that group, it was Nelson Sanchez Pintos and several others good colleagues. Daniela de Souza, Claudio Flaucinho, there are many of them. There was that point. Nelson was saying that sepsis is a dysregulated response, immune response, and it must be some kind of other organ, not the first one, other organ, to be impacted, to be to have the failure, and not from the first one, but to say sepsis, there must be another organ that is failing. That's a very good, and I think for research, for drugs, for antibiotic, and how to do it, this is a good thing. But always, I think, why we want to put something or to say something, this is sepsis. Sometimes for a better research on how to do it, but the other is to reach those at the bedside and the bedside to the patient. So sometimes for them, when we say sepsis, we just saying take care, open your eyes, open your mind. Maybe you are in a position that you could not, maybe this is a pneumonia, this is only a pneumonia, but maybe it's a pneumonia and is beginning to fail, for example, to have renal failure or to have hepatic failure. Sometimes you cannot know because you don't have a laboratory, you don't have how to take an echo or other things because you are in a low research setting or a middle research setting. So You only have to see that this is a patient with an infection and is not doing good. Just open your eyes, open your hair, and the phrase, I love the phrase that you always say, that listen to the patient. Just don't send him or her to home and give oral antibiotic. Just take care. And if you send it to home, just check how it's doing the next hour. So open your mind. So I think that sepsis must have two different points for the researchers, for the intensivists, for the ones that are working at the high or middle resource hospitals, and the other for the peoples in the primary health care, for example, on in low resource settings.
Sure, that's a great point.
That usually happens, you know, this connection between researcher and clinicians, because what clinicians want to know is, well, I have detected this child who is, I think, septic. Well, let's get him fluids, start wide spectrum antibiotics, give oxygen, start even dopamine, adrenaline, say. So it's like a cookbook, you know, many times. Those things about phenotypes, about precise definitions of sepsis, many times it's like a closed box discussion between researchers, and we forget about clinicians. And in particular, for those clinicians, like Roberto was saying, who work at really low resource settings. So for those colleagues, pediatricians, or even physicians, general physicians, who have not pediatric background, but are in the front lines, taking care of those children in low resource settings, what would be our main recommendation? I mean, we agree that that patient who looks bad can go home, but well, we are in the hospital, the general hospital. What should they do? Or at least what should not they do? Or should not do?
So I really I think what Roberto said really resonates, and it's really important that clinicians should have a very highly developed antennae, and I think most experienced pediatricians are good at this. So parents and caregivers should be your partners, so they know their child best, and they can tell you that this child is not the usual self, has not been active, and has been sleepy, lethargic, intake poor. So some of the questions in our emergency with the triage questions are exactly this. Is a child less active than usual? Are the hands and feet cold? Has not been drinking much, not been passing urine. So compared to the usual pattern of urine output has a decreased. So that parental part is a huge component, and along with signs like, I mean, that cold hands, feet, and fast breathing. Parents are very good at telling you that breathing is fast, and those can be corroborated. I think what you said, Roberto, that observe for a while and look at the pattern. It's also called an educated eyeball. Okay, the best monitor is the educated eyeball. So you see the child at, say, 9 in the morning, and then 20 minutes later, another 20 minutes, another 20 minutes, you have a very good idea. Is it things are going better or worse? What is happening more? So I totally love what you said, Roberto, that there's some research definitions and there's a clinical definition. It requires a lot of bedside. You have to train yourself and train the people in your team, but it can work. And although in this newfangled world, everyone is so busy, staying at the bedside of one child may not be very practical. It is a very good it is a very good practice and one that we should not lose sight of.
And you are talking about the power of clinical observation and how that child behaves after you start the treatment.
Yep.
I guess, well, you are at the bedside, you tell parents, well, let's see him or her, how he will behave the next few hours. Perhaps we start antibiotics for pneumonia, but you are suspecting that perhaps that lung infection is beyond the lungs. So you start, I don't know, try to feed him, feed the child, try how he responds. And the power of observation gets nulled once you have guidelines which say, well, in the first hour, you have to do this and this and this and this. And many times you are doubtful about what you should do or what is the precise order of each intervention. Because I wanted to ask to you this, try to elaborate a bit more about, well, one thing is sepsis and another thing is septic shock. Are they the same? How can we detect septic shock and cardiovascular failure in that child? And we have already have conversations about the power of clinical observation and capillary refilling time, which is often neglected clinical sign that we have everywhere, every time, and it's costless. Could you elaborate about cardiovascular monitoring from the clinical perspective in low resource setting?
So that who are you asking the question to?
Both. Ladies first, perhaps.
You first, Suchitra.
The question is.
I love. Come on, go you. You go first.
So this is. So you're asking about septic shock in a low resource setting. How would you recognize? Yes. It's. I think adults have it so easy. They have a lovely mnemonic called HAT. Right? It's hypotension, altered mental status, and tachypnea. Right? So they have hypotension, it's less than 90 systolic or less than 65 mean, and altered mental status and tachypnea more than 20. It's so simple. But we have these children at all age groups.
They don't treat infants.
So a heart rate of 100, it's almost bradycardia for a 3-month-old, and it's tachycardia for a 10-year-old. It's both extremes.
Yes.
Right? The same number. So it's much more challenging for children, right? So yeah, it's a little harder, and I think we can make it easier for them by putting some charts. And most of our nurses and junior residents carry charts of what is the normal range, and they always forget, because whenever I ask, I go to the emergency, ask, why is this child tachycardic? And the first thing they say, the child is febrile, the child has fever of 101. So then I had to go to the entire exercise for each degree, temperature, how much does the heart rate rise? Is it proportionate or disproportionate? So I guess there's a lot of teaching involved, and it's not a single sign. So it would be at least 2 or 3 signs. Otherwise, you can go down a rabbit hole of giving fluids for every tachycardia.
Yeah.
Right. So, and they can be tachycardic and irritable for 100 different reasons. So it's useful to put at least 3, I would be comfortable with at least 3 signs, such as tachycardia or unusual tachypnea, which doesn't have a lung cause, and perhaps a capillary refill abnormality or a flash refill. So 3 or more, it's reasonable. If just 2, you can just keep observing and seeing that if it just doesn't just settle, or is it something to be taken note about? If it's just 1 or 2, you're not pushing the child into irreversible shock by not doing too much. At the same time, it may stop you from over treating those who don't have septic shock.
Yes, so of that child you were talking about with pneumonia, who is tachycardic, who is feverish, who is breathing fast.
Yeah.
Well, you start resuscitating him. No,
Yeah,
perhaps yes or no.
No, because again, even in the surviving sepsis guideline, it says that if they give you 3 hours if there is signs of sepsis without shock. So you can observe the patient. If possible, send labs. If not possible, keep observing. You're doing some treatment. You're allowing the family parent near the child. So how is that observing? So there's 3 hours time, which I feel it's a nice addition to the new guideline, that if there is shock, cold extremities, altered capillary refer, out of proportion tachycardia. I always worry about tachycardia that is going 150, 160 when there's only mild temperature. That's a really useful sign. And it tells you something's wrong, but it doesn't tell you what is the problem. It doesn't tell you what is the treatment, but it tells you, hey, I need help. Something's wrong. Yeah. Right? So looking at
it is not a sign of fluid resuscitation deficiency either.
Correct.
I mean, you don't have to use fluid for every child.
No.
Roberto, your take.
That's the point. It's very difficult. Many times we are saying they have to recognize this, they have to recognize that, but only a few times we ask them. I mean, for example, the primary health physician, what they think about sepsis. I went several months ago and to talk about them, and because there is some kind of sociological research about the social representation. The social representation is how the people learn, how the people know that something, this is the concept. And many times this social representation, even in physician, is make between the technical points that they learn, that they read, that they go to hospital, but also because of the social context around them, what they feel. And many times physicians at the primary healthcare, they think that their job is only for some kind of primary healthcare, of prevention, of that this is a very good idea. And sometimes when they have this kind of child, they think that is something that they can do anything, even if they are 10 minutes from the hospital, even if they are 1 hour from the hospital, even if they are 100 kilometers from the hospital. So how to teach them to be alert for the signs of this child that is going from fever and is getting bad. So this is something that I try to think about how to talk with them. We have here in Argentina, several years ago, there was some kind of protocol about bronchiolitis. And there is a paper that is in every part of Argentina, every primary health care, every hospital, and with some 2 or 3 points, simple points, how to do with the child with bronchiolitis. Maybe we have to update that paper because it still have bronchiolitis. But the one that made that paper, it has salbutamol and it's given salbutamol to everyone. But the point of that paper was that it's in every hospital, every place, the low resource place from Argentina have this paper, and it just to look at the child with simple points, to look if they are good or they are bad. We get better treatment from bronchiolitis from them, because we can discuss about salbutamol yes, salbutamol no, and there is another thing, but they take a look on the child, and they send to the hospital earlier, and they use oxygen earlier, and they do something earlier, and that's the point. We are not still finding how to say to the physician, especially in low resource sepsis, when is earlier, when is the time, the exact time, because sometimes we are saying that when we are sitting in our pediatric intensive care, and sometimes that's easier, but to be there, they don't have how to do fluids. They don't have, sometimes they couldn't have, they don't know, they don't have the practice to do a venous access, for example.
But what early means? Because what is early for sepsis management? I mean, we have this time frame of 3 hours, perhaps. Well, you have 3 hours to start antibiotics. That could be early if you start earlier than those 3 hours from the first clinical exam. I mean, you have 3 hours. But well, to move a bit forward, if we have, yes, we have defined that this child has sepsis and this child has septic shock. How can we manage it? What would be your preference of fluid response? What kind of fluid? To what would you expect to detect a positive or negative response? When would you start inotropes or pressors? What would be your first steps in the management of those children in low resource settings?
Suchitra is our Messi in that point.
In fluid management.
I love here Suchitra talking about that, because she not only really have a good thought about that, but she's a researcher on that. So she know, and something special, Sebastián, that maybe no many people know. Suchitra, at the beginning of the century, she was saying something, and after that, she knew that something was wrong. When she was in a position at the pediatric intensive care, and after that, she, oh, wait a minute, I am here, but I have to reach those in a low and middle resource centers around my country. So she changed some of the point to look to that people at that sites, at that context, and that setting, so they could do better. And she began to change some of the concepts, because and that's very important for a researcher.
Outside the ICU, right?
Outside the ICU, not only to say, hey, I think that in my ICU, I could do this thing. These things are important. We must do these things. But especially in dengue, that she knows very much about, too much about dengue. I can do this, but when I am outside my PICU, maybe you cannot do what I am doing. So you take care, look at this, and I love that kind of thinking about how we impact. We tell the people not only sitting in our PICU with great ICU, but also to say them, you can do something, not being in my ICU, but being in your place. You can do something being in your place.
So let me reformulate then for Suchitra. You have first recommendation to what to do first outside the ICU and then within the ICU environment. Are they different recommendations?
Yeah, so now you put me in a spot. I wasn't, I mean, it's logical. It's a very logical question. But I think Roberto and I are involved in kind of challenging the standard recommendations and trying to see, like, how to make it more practical for patients, for people working outside very rich ICUs, right? That's the thing. Like, many patients can't afford and don't have beds in big ICUs. So our job is to try and see if the initial treatments can get them better without forcing them into ICU. Let me put it that way.
Yeah.
So some of them will need to come to ICU if they get worse, but some of them you can treat. But it's important we treat the child, what the child requires best, rather than force fit the child to fit into our treatment protocol and then say, okay, if you're better, you go this way. If you're worse, we have something for you. So I'm not sure if I'm making sense, but to that extent,
yes, how not to make a Procustes bed from the guidance. Yes.
Yeah, I really feel that I think to some extent it is all of our problem. If we had a lot of evidence and we are so busy at the bedside, we don't always get time to keep writing our experiences. All of you all have, I'm sure between both of you, you have so much to teach the rest of the world. But because of that, we are forced to, I really feel that the old concept of giving fluid, and then say that now you need ventilation and now you need dialysis and now you need ICU. So and then say we rescued them. So you literally, drown them and then say we rescue them. So the whole thing is such an elaborate, needless complication. It will keep the ICU very, very busy. It will keep all your resources, equipment busy. The management's going to be quite pleased. But I don't think we're doing the child or the family any service. Right? So to that extent, I think that we have to come back to the fact that we're discussing with Andrew, and Andrew said Andrew Argent, just like the ABC concept of resuscitation has been challenged, and it's now, instead of airway breathing circulation for resuscitation, it's now CAB, right? So it's high time. There is no single trial in the best center in the whole world saying fluid bolus benefits. There's only a bundle which benefits, not that fluid bolus benefits. And we have Kate Medlin's study showing that fluids can harm. And there's a second very recent study from her group that showed the children who died after fluid bolus, all of them had cardiac dysfunction. So it was only about 30 patients and 6 died, and all of them had cardiac dysfunction. So I think we're coming around to the fact that on one hand, we shouldn't demonize fluids. It's the large volume and the speed, push, 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 which may be a problem. Certainly many patients will need, I think, a small volume of 10 ml per kg. It's kind of reasonable, but I would go one step more and say you would prioritize that 10 plus maybe the second 10 if there's a clear history of fluid loss. Some children, the parents will tell you intake is poor, there's diarrhea, there's vomiting.
Yeah.
So the clear history of fluid loss, you're on very firm ground, right? But a child who's maybe just unwell, lethargic, certainly they won't be drinking the way they would. So 5 or 10 ml per kg given over 30 or 60 minutes, it's not going to harm many patients. When you're giving an empiric treatment, let's not make it dangerous. Let's go slow. And as Roberto said, listen to the response. So I would prioritize fluid, the first bolus, and maybe the first bolus of 5 or 10, and maybe up to a max of 20, only if there's a history of fluid loss. And the others, I would just give about 5 and 10. And also look at the other things which are like what is happening in the Andromeda shock. They are also looking at the pulse pressure. So some children are in vasoplegic shock right from the start. And sometimes it's interestingly that white pulse pressure takes fluids to bring it out of hiding, so to speak. They look cold and shut down, and even 10 ml, 20 ml per kg, suddenly their pulse pressure is wide and the pulses are bounding. So if it is a wide pulse pressure, even on a non-invasive blood pressure, then there's a relative deficiency. It's there somewhere in the body, but sitting in the wrong place, right? You need to coax that fluid to come back to the heart and do some work in the circulation, rather than give more and more fluids, which is going to vasodilate even more, right? So I think a little bit of fluid, let me say that a little bit of fluid, 5 or 10 ml given gradually, just trickle in for a while, it's unlikely to do a lot of harm. And importantly, it buys you time till you figure out what to do next. It gives you a sense of what is happening to the child's circulation. You can start immediately, you can start seeing the story coming from the child. I'm doing better. I like what you're doing. The heart rate is coming down. The capillary refill is improving. So clearly the child likes what you're doing. So then, and if there's no worsening, so when you're looking at better or worse, you have to look at perfusion, including cap refill, heart rate and cap refill. You have to look at pressure parameters. So we are fixated on MAP and systolic BP, but we have to look at pulse pressure and diastolic. So perfusion, pressure parameters, and filling parameters. So that would be, how are the lungs tolerating it? So for all of these, perfusion is better, pulse pressure is not too wide, and lungs are clean, by all means, give another small bolus, right?
If not, so listen
if
to the
not,
patient.
So,
we are in this path of listen to the patient. Watch him. So you give these 10 ml per kilo, and the child is just the same. And you have started, say, an hour ago, just the same. The knee-jerk reaction would be another fully bolus. That's what the survival sepsis campaign say to me to do. Give another one.
Suchitra,
give another one.
Tell us about. I love the concept that I hear from you and read for you about the test paradigm, the fluid test, the inotrope test, the vasopressor test, because I think it's very practical for the physician bedside. So what to do? This concept, not only the guidelines are very good, they have many bibliography and many research that was searched for giving us the best evidence. But when we are to the practice and you are saying, this is good, you have this guideline, what to do and not what to do. But when you are bedside, you must do with all of those thoughts and with all of those evidence, you can do this test, this fluid test, this inotrope test, this vasopressor test, and check it to the patient response. What is he telling you, and how is he responding to what you are doing? Tell us about the test that you are thinking about, and not only you, but also adults are thinking about this test to treat the patient with septic shock.
Yeah. So, like I said, it's I mean, each time you're testing the circulation, because it's hard to measure the cardiac output, to always do an echo. But this kind of testing you can do during transport, you can do wherever you are. You just need to be at the bedside. That's the hardest part, right?
Stand there, standing there.
You just stand there, grab your cup of coffee or whatever it is you're drinking now, and then
Mate.
Yeah, mate.
Mate.
Right. So
No,
yeah,
but it's from
very
Uruguay,
good. You're
not
well
Argentina.
prepared.
Later I will tell you. Go on.
Okay. Yeah. So grab that.
It's like tea,
caffeine.
Suchitra. For us, it's like tea. It's something like tea. It's
Like tea.
something.
It's an infusion. It's a fluid enteral infusion.
Yeah. Correct. So yeah, with a bit of caffeine, I'm sure. So yeah, so if you can be prepared. So I think you don't need much resources at all, but you need to be prepared and follow the clues. So 3 main things, whichever test you're doing, is actually boils down to very simple things. You are testing with 3 interventions, and you're monitoring 3 aspects of the circulation, right? So the test, like Roberto said, is fluid, pressor, inotrope in any order. You can select any order, but look at the response, and most of the time you'll find out what is the next step. Sebastián asked if nothing has changed. So nothing has changed, what will you do? So I would look at all 3 very carefully. So the cap refill is still 5 seconds, still tachycardic. So perfusion is still poor, not worse, not better. And blood pressure, very important, because fluids can do many things with blood pressure. Sometimes in 50% is dilating the circulation. So look at not just the MAP and systolic, but also the pulse pressure and the diastolic. So if the diastolic hasn't fallen, the pulse pressure is the same, so we need to track it. And the third part is any new respiratory signs during the fluid bolus. No worsening of the respiratory, no increased oxygen requirement, no work of breathing, mechanics is the same. So it's actually quite simple to monitor filling, pressure, perfusion, okay, after fluids. If there's no worsening, there's no reason not to give more fluid. Maybe he needs more filling. He's not showing any intolerance. So I prefer the term intolerance rather than overload, because much before they get that 10% overload, they can show signs that I don't like that fluid. So that little bit of increased rate of breathing, the saturation, which is coming down a little bit. So lungs are wet, lungs are getting wet, there's some capillary leak. So if there's any intolerance to fluid, I would stop, but I would go to 10 plus 10, maybe 30, there's a clear history of fluid loss. But after about 20, we are thinking very strongly, should I do an inotrope or should I do a pressor? And both of these can be done via a peripheral line. It is very safe if you dilute it up to 10 times your central line concentration. It should be a dedicated lumen. So antibiotics and flushes shouldn't be going in the same line. It should be a dedicated lumen, somewhere proximal, a size that's at least 20 or 22, not a very tiny one. So, and maybe if they're still needing that inotrope for 4 to 6 hours, you should think very strongly about either changing to a central line or sending the patient where they can get a central line. Because if they're needing it for 4 to 6 hours, the child might need more monitoring that is possible in a peripheral center, or we'll have to get help and guidance from our senior colleagues. So I'm saying that give 10, 10, 10, maximum about 20. At the most, we rarely give 30 unless there's ongoing fluid losses, and then think of inotropes. If the pulse pressure is less than half of the systolic BP, so that's a narrow pulse pressure, I would choose 0.05 of adrenaline or dobutamine, depending on the blood pressure. The pulse pressure is wide, so a pulse pressure of more than half of the systolic blood pressure is wide. And I really like what norepinephrine does, because we've had a lot of studies with norepinephrine, and I've come to believe it's like made for each other, norepinephrine and septic shock. I don't believe pediatric septic shock is very different from adults. I believe that there are different phenotypes. Children and adults have different phenotypes. So some have cardiac dysfunction, some have pure, bounding hyperdynamic circulation. And it's sometimes hard to tell the difference when they first come.
So
but
you have missed to mention dopamine, which is in my country, for example, is the first line.
It's a first line.
In the first line.
Great question.
Inotrope.
Great question. Very
in
good
medicine,
question.
in general, we used to impose like scenes. Don't use dopamine. It's like 2022 scene. No, dopamine for septic shock is a scene. They don't use it, but we were using every child with dopamine 10 years ago. And I'm sure dopamine has saved thousands of lives. So
correct.
As we tend to do the same once and once again, give fluid overload doesn't exist. Then we started saying, no, don't use fluid because fluid is advanced, fluids and so, and now dopamine. So you were saying about adrenaline, noradrenaline or norepinephrine, like you say, but you missed dopamine. What do you think about dopamine? And Roberto, what do you think about dopamine?
The same. It's like I was thinking about football. It's like in my city, I am playing with my friends. I don't have Messi, so I have to the ones that go with the football is myself. So they don't got Messi. So if I got another thing like epinephrine, but if I don't, and I know dopamine, this is like to how you make a steak. I mean the meat, how you prepare. If you are useful to use dopamine, you can use. I love Andrea Ventura from Brazil that made the study. She's a great researcher, and but I think that she the only thing, if you have this and you have this, you can choose, and maybe for us it's better this one. But she doesn't mean to say no dopamine, take away dopamine like in adult. If you don't have in many places they do not have norepinephrine or they do not have epinephrine and they only have dopamine, use dopamine.
No, because for years, intensivists, we were saying, please use some kind of inotrope before they arrive to the ICU. So it was a really difficult task to convince or to try to make those physicians working outside the ICU to start inotropes early. And they start doing that, at least in my country. And they got used to start dopamine, for example. But once they are used to start dopamine, at least dopamine outside the ICUs, now intensivists are saying, no, dopamine is not used.
Sebastián, do you remember when the time when to use an inotrope and a vasopressor, you must have a central venous line? So,
yes, of course. Yes, you need a central venous line before starting strokes. Many children died because of that.
They died because they were waiting 2-3 hours for a central venous line.
Oh, right.
Yeah. Yes. So
with dopamine,
should we
with dopamine,
avoid dopamine?
Yes, such a great point, Sebastian. I'm so glad you brought that up. It's such a cheap drug, so much familiarity with it. And as you said, it saved countless lives. So what I advise people who call me for help when they're setting with not very sophisticated settings, and they say, we just have dopamine, I say, by all means, start dopamine. Because you need to help your patient, right? Your child has not read the latest recommendations. He just needs help, right? So you need to help your patient. But if the child is not improving and dopamine's your only agent, don't go to toxic levels. I think, catecholamines, it's a nice paper called the Jekyll and Hyde effect. So it can save lives, but it can also cause a lot of excess myocardial, work and tachycardia and supply-demand mismatch. And have you heard of it's called dynamic LVOTO. So it's like the heart is banging, slamming on itself, right? So, and there'll be tachycardia and low blood pressure. And what is the response of the physician?
More fluid.
To give even more. No, more fluid and more
drops. Yeah.
More everything. More fluid, more pressors, more inotropes.
We are intensivists. We like more and more and more. Yeah.
More and more. We cannot sit quietly. So I feel that many of these agents are good, but because they're good, we tend to expect so much of them, and we use higher and higher doses. So to my mind, dopamine is like a very good generalist. It can help the heart, it can help vasoconstrict a little bit. It can, it just helps the circulation. But a good generalist knows when a specialist is required, right? Yes. So a generalist can do so much, can look after many things, but sometimes you need a specialist. You might need epinephrine, or because if there's too much tachycardia with dopamine or epi, both of them have a lot of tachycardia. So if you need a little more alpha effect, rather than go up on dopamine or epinephrine, it's so much safer and more effective to bring in a bit of epinephrine, norepinephrine. So in other words, I think dopamine is still a very good agent that is cheap, is widely available, that has saved lives. There's familiarity. Clinicians should use that if that's the only agent available. Many children, the shock might resolve after a few hours, and that's all that's required. Why should they send that child to another center? If it doesn't respond, the child is maybe showing a trend, everything going downhill, and they don't have any other agent, then they should ask for help or send the patient.
Yeah, but say if you are in a hospital, you don't have an ICU, you are in a low resource setting, you started resuscitating this child, you have started antibiotics, you have, well, first of all, you have detected sepsis, septic shock, you started resuscitating, you tried to correct everything that was wrong, glycemia, calcium, you started inotropes, you are with adrenaline, you already have, and 2 hours after, the child is still in a bad shape, but you are like 100 away from the ICU. So you call the intensivist. What would you say to that colleague? Because I think mechanical ventilation, it's a challenge for most physicians. So what would be the recommendation to start mechanical ventilation, or whether it's what would you suggest to those colleagues far away from, because when we go to congresses, you know, recently we were in Lima, in Peru, and we were talking about inotrope, what were our choices, okay, let fluid overload. And one colleague from the mountain in the Andes region, they say, hey, I don't have MESI, I don't have ECMO, I don't have anything. I don't have a central line, but yes, I have really septic childs in my wards. So what shall I do for that very, very, very sick kid who is already given fluid bolus challenges? They become toxic because of fluid, they didn't respond. And then I started, say, epinephrine, I am giving him oxygen, but I have anything else to do here. I have to transfer it. So what would be your recommendations from the very first 3 hours we're there, but they need an ICU? What shall they do? I know, Roberto, you love telemedicine. You have been really, it's a tool, a really powerful tool to try to use telemedicine, our smartphone, to give recommendations to those colleagues far away. But what would you say if you are the receipt center? You know, you are like 100 away from that sick child. What would you recommend?
Roberto?
For me, I
Yep.
the same thing that to be near the patient is to be near the physician that is near the patient, and to say them that what they can do, what they have to, the context, where they are living, or they are approaching that patient, and that we still see patient even treating by us that they die. I have the last today I have to go to the hospital and to be 24 hours there. And the last two Tuesday, I have child that died from sepsis. That they are even in our middle resource centers. The childs are dying for sepsis.
They die
But
anyway,
the
yeah.
thing that, yeah, but the thing that we must be near that physician, near the patient, is to try to help him. I always tell about Sister Veronica, who is in Tanzania, this nun from Venezuela that is working in a rural place in Tanzania. She always asks me about how to do with this septic patient, and many times I just telling her that what simple things to do, even when I know that she's very limited in her context to do something. But we are not gods, we are only physicians. The only thing we do not have to do is to leave that colleagues, that physician alone. So we must try to be there, maybe sometimes in a virtual place, but to be there, so the patient and the family knows that we are doing the best for that patient. And maybe there is this context that is low resource settings that many think we cannot do it and they will die.
Would you recommend to start or to try to intubate and start mechanical ventilation? Yes or
sometimes
no?
Sometimes in our places, in our cities, for example, 500 kilometers away or 400 kilometers away, there are anesthesiology experts that sometimes we tell them, to the pediatrician, call the anesthesiology so they can intubate the patient. And if you have, there are many, sometimes neonatologists that or nurse, so they can put in a venous line, a peripheral venous line, so they can begin with inotrope or vasoactive drugs, so they can reach better to our units. Sometimes 200 kilometers away, and sometimes we are monitoring them by with the phone, with the smartphones, when they are coming with the ambulance.
Suchitra, do you usually receive children far away who have already started resuscitation? What would be your recommendation regarding intubation and mechanical ventilation outside the ICU?
Intubating a child who's, when you think of intubation now, it's not as early as we did in the past. Earlier, we said that if they got some fluids and inotropes to take off the work of breathing and improve perfusion to the other parts of the body, we would intubate earlier. But I think because we are giving less fluids and we are getting control of the circulation a bit earlier, we are intubating almost only about 15 to 20% of the number of patients that we did about 8 years ago. So it's really come down. So I would call, in the first place, I think if they hadn't given a lot of fluids, the chance of needing intubation is much less. But despite what you do, some children can get sicker and sicker. So like Roberto said, get the most experienced person available to do the intubation. The drugs are very important. So most people think midazolam, fentanyl are very safe drugs, but they can be, they're very dangerous drugs, especially deadly. I'm very scared of midazolam. So that combination of when you intubate, you're taking away spontaneous breathing and also giving midazolam, it's a double whammy for the patient.
Yes.
Right. Suddenly they're on positive pressure ventilation and there's less venous return. And then you're given midazolam and it's dilating the circulation. So
you lose cardiac output all in a sudden.
Very precipitously.
In my view, this is a personal opinion, I would rather not to intubate. Because it's not just intubated, it's those drugs needed to induce coma, and then you have mechanical ventilation. And when you start mechanical ventilation, you are changing the rules of everything.
Yeah.
And you will need sedation. So I would rather say, well, take that patient to me and I will take care of him. You have done a wonderful job. I would have done better than you if you started inotropes.
That depends on the distance, Seba. Sometimes if you have
3 hours, 4 hours,
20 minutes, sometimes I have 6 and 5 hours. And it comes with many times. Many times we do not have a physician to be at the ambulance coming with the patient. Sometimes the nurse is
same reality here.
But same, I mean, I agree that if it's possible to avoid intubation, that will be the best. But a child whose mental status is going down and unable to protect airway, it's a very difficult decision. And
Yeah.
really, I mean, I hate to be in that kind of position. So,
Yeah.
I mean, just work of breathing shock, we can manage without intubating, because especially it's after you put the tube, you have to monitor the ventilation, and the tube can get blocked or dislodged during transport. So there's many things that can happen even with the tube. So it's a very delicate situation. I'm not sure whether we can, you know, it depends on the people accompanying, it depends on the distance, it depends how sick the child is. If you can protect the airway.
Yeah, I know that it's a
that's the point.
frustrating conversation. Because
that's the point. There is
we all
no
know
yes
that
or no.
that child would die, would probably die if they need, like, if they are so sick and they need these 5 hours transport, they probably die or arrive to us. That's
Yeah,
a difficult task, a
Yeah.
difficult situation for everyone. But
Yeah.
I say to that colleague, well, say those parents that he or she is really sick, perhaps he or she won't make it to arrive to the ICU.
There is not an exceptional point that we are get used to sometimes we have this point, if a child is going and after 2 hours telling us the child has died in the ambulance. There is something that we are working. We do not have airware, I mean, plane,
Air transport, yes.
Air transport. So there is something, many times, as Suchitra said, who is the one that will be transport the patient, how is the patient, and sometimes are individual decision that you must do with the other physician that is by the patient.
Well, Suchitra, Roberto, my last question for you is another easy one. Would be, I mean, we work at low resource settings. Many times definitions and recommendations don't fit to our contexts. So what are, in your opinion, the main differences between working in a rich resource settings with Messi and other colleagues and in a low resource settings regarding sepsis management? And what would be your thoughts about how we can move forward in low resource settings regarding sepsis management? How do you envision where we should head, or try to elaborate a bit more in low resource settings? What are the main differences, and what would be your differential recommendations? One setting or the other?
Roberto?
It's a very hard question, a very good.
Many questions, many last questions.
Many
one
questions,
last question,
many
and that's
answers.
5.
Yeah, but I really think
you have 2 minutes.
I getting older, and I try to just to listen to the people. I like to listen to the people, what they think, what they know, what they think they can change. Not only what I mean, but because they know their context. They really know their context. If I do not know their context, I could not say change this. I could say something because of researching, because of the pediatric intensive care unit, but many things I will do wrong if I do not listen them in their context.
Suchitra?
Yeah, so that's interesting that I think that the challenges are more, but it's even more interesting because in a country, I'm not sure exactly how many kind of pathogens you all have there, but a patient who comes in shock and fever and tachycardia could well be dengue or scrub typhus or malaria or staph bacteremia. So it could be any number of organisms. And we've seen after the COVID that they have the COVID antibodies, and any kind of infection is so different. So that previous infection and co-infections, that it's like making the whole complexion of the way they present really different. So it's hard to say that exactly that in LMIC the sepsis is different. It's just a kaleidoscope of so many agents that either come alone or in combination or one after the other. So I mean, I feel that every day when we go to work, it is a fresh challenge and something else that the patients are teaching us all the time. And I think collectively working together, we should, I mean, that's why I was so keen on this document, that together we can get the message out that don't treat everybody as though it is one, like one size fits all. Try and look at the differences and try and have a fit that suits the patient. And that fit, you cannot predict in the beginning. You have to fine tune as you go. And as you go, you know that you're going right or wrong, and you can really fine tune further. And if the child is not getting better, that's a problem. So keep your mind open. Keep your mind open. Look for what have I missed. Talk to your colleagues. Sometimes a fresh eye is what it takes to discover that you missed something. I have a very good team, and we are always talking to each other, and I think the patient benefits. I'm not sure if this is the answer to the question that Sebastián asked. But
it's a work in progress question. Answer. Yeah.
That's right.
Sebastián laughed because I told him someday that sepsis is like wedding. You know when it begins, but you do not know when it goes.
Yeah, it's been a wonderful morning for me. Thanks, Suchitra. Thanks, Roberto.
Thank you very much.
And listen to the patient. That's my main message. Yeah, listen to the patient.
The patient. That's right.
So bye bye.
Thank you so much for calling
don't worry. Don't worry.
Don't worry. Don't worry.
And Mate is from Uruguay. We have settled that discussion.
Okay. Right. Okay.
A pleasure, Suchitra. A pleasure.
Pleasure. Thank you so much for calling me.
Have a nice day.
Thank you, Sebastián and Roberto. Have a good day. My day is over. So have a great day.